Hello everyone, I am Dr. Utsub Bansal, faculty at Marrow. Here I am with the INI-CET May 25 ophthalmology recall, and all I would like to say is that there were a total of 8 questions asked from ophthalmology, as is usually the norm in INI-CET exams. 6 to 8 questions from ophthalmology, and again, as is the norm, out of 8, 6 you could have closed your eyes and done it, and 2 were a little tricky, but nothing out of the world. Yes, so let us approach the 8 questions one by one. Let's start with question number 1. Probably the easiest question asked, a straight direct question if you had ever read the topic. Advanced diabetes mellitus is associated with. So, as far as I understand, a lot of students were thrown by the word advanced. Diabetes mellitus, if they're talking about advanced, does it mean something else? No. So, see, advanced diabetes mellitus, or rather advanced diabetic retinopathy, that would have been the better way to term it or frame it. But at last, these are all recalls. We are unsure of the exact language that has been used, right? A word here or there gets slipped, right? So if you're talking about advanced diabetic retinopathy, what does it mean? It means basically a diabetic retinopathy which is now become complicated, which has caused complications. So in advanced diabetic retinopathy, we say what has occurred. We say has occurred retinal detachment. What has occurred? Rubeosis iridis and vitreous hemorrhage. If diabetic retinopathy has caused any of the three things as a complication, as we know, we have studied it as a part of complications of diabetic retinopathy. So then it gets to be known as advanced diabetic retinopathy. That's all, nothing else. So basically, they're asking you diabetes mellitus causes retinal detachment, which all of us know. All of us know retinal detachment is the most common cause of blindness. Yes, most common cause of blindness in diabetic retinopathy. Rubeosis iridis causes hyphema, and vitreous hemorrhage is the most common cause of loss of vision in proliferative diabetic retinopathy. Yes. Now they're asking you which type of RD. So I think it is pretty clear. We already know this, that diabetic retinopathy is the most common cause of tractional retinal detachment. So the answer is option C. There is no doubt about it. If you have gone through the notes, if you have ever seen the videos, you know that the most common cause of tractional retinal detachment is diabetic retinopathy. What are the other causes? Retinopathy of prematurity, penetrating trauma, or sickle cell retinopathy. Tractional retinal detachment is different from rhegmatogenous in the fact that it has no break. The patient does not experience any photopsia or floaters. So these three features, breaks, photopsia, and floaters, these are specific for rhegmatogenous RT. Yes, and it occurs due to static vitreous retraction, that is, the vitreous is pulling the retina. And that is what we will be able to see in this image. We will be able to see fibrotic bands of the vitreous which are forming membranes and which are pulling on the retina. So we can see all this, you can see. This is a fibrovascular proliferative membrane which is pulling the retina, applying traction. And due to that, in the center of this traction, we see a tractional retinal detachment which has involved the retina, and a little bit shallow retinal detachment has occurred in this area also. Am I clear about this? Okay. Now, question number 1. Any doubt? I don't think so. It's pretty easy question. Rhegmatogenous RD, if you want to revise, the most common cause is pathological myopia. And exudative RD, as we say, the most common cause is choroidal melanoma. No RD, the most common cause is live a healthy life. Right. So moving on to the next question, second question, question number 2. Again, I think I'll keep on saying these were all the easiest questions. This was also one of the easiest questions of your exam overall, I will hope. Amongst the following options, which viruses cause acute hemorrhagic conjunctivitis? First of all, please realize, I have told it thousands of times, this is the single most important viral conjunctivitis which keeps on getting asked over and over and over and over again, right? This is also called as Apollo conjunctivitis. Now, Apollo conjunctivitis or acute hemorrhagic conjunctivitis is caused by, okay, PCEA, CEA antigen, and P you can just remember, PCEA. P for picorna virus. Now, picorna virus, two types. Coxsackie, keep seeing the options. A24, enterovirus, 70, and then secondly, adenovirus 11. Right? That's the simple way. That's the only four words you need to remember. So the answer is, which of the following options cause acute hemorrhagic? Coxsackie A causes, enterovirus 70 causes. So 1 and 4, answer is option D. As simple as that. If you've ever gone through the notes, if you've ever seen videos, you would have seen this, the same thing that I've written: picornavirus, enterovirus type 70, and Coxsackie A24. That is all the knowledge that you needed to be able to solve this question. And if you've never seen a photograph, this is how it looks. There is a complete conjunctival hemorrhage, which is affecting the lower palpebral conjunctiva as well as the bulbar conjunctiva. So it's like complete red. All the parts of the conjunctiva, UPC cannot be seen here. That is, the upper palpebral conjunctiva cannot be seen here. But if it had been seen, that would also have been completely red because of excessive hemorrhages, acute hemorrhagic conjunctivitis. I hope we are clear about this. There is no confusion. Question number 3, guys. A 53-year-old farmer, so the first clue is farmer, got a corneal transplant. Oh, corneal transplant is already mentioned for fungal keratitis. So farmers get fungal corneal ulcer, for which he had to get corneal transplant done. Okay, clear. What medium is used to store the donor corneal graft? Okay, so the media for storage is being asked. And what suture material is used to suture the donor corneal graft? So basically the question is on keratoplasty. Yes. What do we know about keratoplasty? We know about keratoplasty that keratoplasty, the donor cornea, can only be taken after a patient is no more. That means a live donation is not allowed, like for, let's say, a kidney. Yes. So donor cornea is only taken from a dead body. Yes. Then donor cornea is always 0.25 mm oversized compared to the graft area. Then the donor cornea and the host cornea, they are sutured together. As you can see in this image, they are sutured together by interrupted sutures. Now, between the harvesting of the donor cornea from the dead body and the time it takes to reach the host cornea, what is the media used to store the donor corneal graft? So, what names have we heard? Have we heard McCarry Kaufman media? Yes, we have. Have we heard moist chamber? Yes, we have. Ethylene glycol and polyethylene glycol, I think they are lubricants. They have nothing to do as a storage media. So if we have ever read about these names, then two options were clearly ruled out, option B and option C. So the only doubt could have been between option A and option D. Now, both are media, but which suture is used, Vicryl or nylon? So if you have even a little bit of suture knowledge from your surgery, yes, Vicryl is a non-absorbable suture, whereas nylon is a absorbable suture. So which suture is used here? 10-0 nylon. 10-0 is a very thin suture. It is self-absorbable. So after some time, it will get absorbed. Yes, that's the suture that is used. So the answer is option D. If you want to revise, we know that storage media are short term or intermediate. Short term are up to 48 hours, even up to 72 hours they can be used. The first is 4-degree moist chamber, and then the second is McCarry Kaufman media. This is also maintained at 4 degrees Celsius. Intermediate up to 2 weeks, we can use something called as an Optisol GS media. And then we have long term. Do we remember long term? As we have said, we don't prefer long term. This is up to 35 days. We can do minus 70 degrees Celsius cryopreservation, because after cryopreservation, the normal corneal tissue is the quality or the that damage is so much due to cryopreservation that it does not help. And this is what has been taught to you. This image was also shown. A lot of sutures are already getting absorbed. A better image is shown to you in the question, right? So as I said, this was a tricky question, which, if you had put your head down, you could have at least answered either A or D. You would not have, left it. So an educated guess is better than a leave. That's what I always say. So McCarry Kaufman medium with nylon, that's what the answer is. 10-0 nylon. Okay, that was a question which I was not expecting, but which had been asked. INI-CET sometimes does ask these questions also. Am I clear? Moving on, please. I hope you remember already, or I'll just do it for you, that keratoplasty, if we are talking about, it can be of two types. One is penetrating keratoplasty, that is full keratoplasty, and then the other is lamellar keratoplasty. Lamellar keratoplasty is of two types, DALK, DAL, or DSEC. DALK means deep anterior lamellar keratoplasty, and DSEC is just for the superficial layers. So penetrating keratoplasty, DALK, or DSEC, these are the three main names. Please go through the uses. Again, it may be asked. Moving on to the next question. A 60-year-old man, question number 4. A 60-year-old male obviously will be a man, with a previous history of cataract surgery 2 weeks back. So, this 2 weeks was the confusing point in this question. Presented with diminution of vision. Okay. Visual acuity 5 by 60. Obviously, there is diminution of vision. AC cells, anterior chamber cells, vitreous haze, and no fundus details visible. What is the diagnosis and the organism causing it? After cataract surgery, the patient has loss of vision. The patient has AC reaction, that means AC inflammation. And the patient also has vitreous haze, that means the patient has vitritis. Now, one word which we could have been looking for, which is not present in this question, is hypopyon. Had hypopyon been mentioned, our case would have been pretty simple. Hypopyon, pus along with all this would have been made it a case of endophthalmitis. But hypopyon is not mentioned. Still, what are the options? Okay, the first option is endophthalmitis. The second option, which confused a lot of students, was toxic anterior segment syndrome. See, toxic anterior segment syndrome presents within 24 hours of surgery on the first post-op day. Okay, it is due to viscoelastics or some other product or some other dye, drug, something left in the eye which has caused a reaction due to viscoelastics mainly. But it responds very well to topical steroids. So after 2 weeks, if the patient is complaining, number one. Number two, there is no vitritis. This is by name C, toxic anterior segment syndrome. So I don't think this should have been a confusion. Then sympathetic ophthalmitis. Sympathetic ophthalmitis occurs due to penetrating trauma. Okay, so surgery is a penetrating trauma, but penetrating trauma to ciliary body. And the sympathetic ophthalmitis, it affects the non-traumatic eye. So if cataract surgery was done in one eye, the problem should have also occurred in the other eye, right? Does not make any sense here. So that means you're essentially left with only endophthalmitis. So now endophthalmitis we know is of two types: acute onset endophthalmitis post-op or late onset. Acute onset, this is just a photograph, we will come on to it. Acute onset we study within 7 days. Late onset we study usually 6 weeks to 6 months. I think that was the problem. 2 weeks was given, sir, none of the timeline. But I think you can understand that 2 weeks was closer to acute onset. So as taught to you, the answer would have been acute onset post-operative ophthalmitis, Staphylococcus epidermidis, also known as coagulase negative staphylococci. That should have been the answer. So in all likelihood, the best answer out of the given options that have been told to us was option A. It is a case of endophthalmitis having Staphylococcus epidermidis. Now, what about the image? What can we see in the image? See, we can see circumcorneal congestion. We can see hazy cornea because cornea is also hazy, and then there is an AC reaction. There must be cells, and there must be a lot of AC flare. And along with that, we see a hypopyon generally. This is the classic photograph of a post-surgery endophthalmitis case. Please remember, endophthalmitis is treated with evisceration. Please also remember, endophthalmitis, there is no use of systemic steroids. That is the two classic important points on which questions are made, and I do hope you will be able to remember them. Right, guys? Moving on to the next question. Question number 5. Okay, this is the question which is very easy, but which split the country into two, I think. People said this or this, but I'll show you both the things. What is the diagnosis based on the given diagram? Comment: nystagmus on third image written on top of left eye. So this is our right eye, this is our left eye. So the comment is it was written over left eye. But this is the confusion. That's why we have not written it in the image. I'll show you both the things. Some people were saying, sir, it was written over the left eye. Some people were saying it was written over the right eye, blah, blah, blah. Let us consider case scenario one. In case scenario one, as is seen on the screen, primary gaze is normal, then right gaze is normal, then left gaze. In left gaze, what do we see? We see that the left eye abduction is present, but the right eye adduction is absent. Right eye adduction means right eye medial rectus, or I can extrapolate it to right eye medial longitudinal fasciculus. Yes or no? I hope you remember the image as I've shown you. Right eye MLF leads to left gaze defects, whereas in which right eye or ipsilateral adduction is absent, but the contralateral abduction is present with nystagmus. Direct question from the notes, I think. Direct image from the notes if this was the image. And the answer would have been internuclear ophthalmoplegia. Okay. But let me, I know some of you are saying, no, 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 sir, no, sir, no, sir, no, sir. Okay. So some people said that the third image which was given was not this, sir. The third image which was given was this. Let us see. And nystagmus was written here. That means some people said that in the third image, in left gaze, the left eye abduction was absent, whereas the right eye adduction was present. That meant, sir, it was opposite. Sir, in left gaze there was a problem, but it was not internuclear ophthalmoplegia. The medial rectus, the MLF was functioning. So, all right, it could have been this. This is just called as reverse internuclear ophthalmoplegia. It looks like internuclear ophthalmoplegia, but it is just the reverse of it. The lateral rectus is not functioning, the medial rectus is functioning rather than the opposite. It is a very rare presentation, though gut feeling, I think even if this photograph was given, this was an oversight. Somebody who was making the paper just put a wrong photo. This should not have been put. But even if this was given, the answer was still internuclear ophthalmoplegia, because there was no option stating reverse internuclear ophthalmoplegia. Third cranial nerve palsy, we already know. We know that there would have been ptosis. There would have been down and out eye. Horizontal gaze palsy is a big term. It means PPRF lesion. It means MLF lesion. It means FEF lesion. Yes. So it can mean any of the three things. Generalized. If you want to give a generalized answer, then yes. The better answer is internuclear ophthalmoplegia. Thyroid eye disease is an absolutely different thing. It presents with restrictive squint. If we are talking about squint, it presents with staring appearance, Dalrymple sign, Stellbach sign, blah, 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 blah. So I think there was no confusion in this, whether this photograph was given or the other variation was given. In both cases, the answer had to be internuclear ophthalmoplegia. All of us are aware that internuclear ophthalmoplegia, or INO, is very commonly caused by multiple sclerosis. Yes. And I think that was the answer. It's pretty simple. No confusion in this. I know, see, for me, it is very easy to say no confusion in this. I'm not sitting in the examination. When you're sitting during the examination, these small points do create a effect on the capability to think correctly. Yes. But that is why it is very important to keep giving your GTs, to keep revising your MCQs, because you want to be able to look into the question and say, I dare you. Yes, I dare you. I will solve you. I am not afraid of you. I will not get perplexed by you. But this can only occur when you are constantly doing the same thing over and over again. Habit makes you perfect. Yes, perfection. We are trying to achieve perfection. We are nowhere close to perfect, but that is what our aim is. And for that, you just need to create a habit. It should be a habit that you are solving MCQs every day, so that no language, no trick in the MCQ can flummox you during the exam. Those 3 hours, 3.5 hours, they are going to define the next 3.5 years of your life. Think how important those are. Each minute is corresponding to almost a long time in your life, right? So let's prepare for those minutes or hours, I'll say. Now, moving forward to the next question. Amblyopia management includes all except. This was a pretty easy question. Again, two options could be ruled out. Out of the two, you could have said, oh, I don't know. All right. Amblyopia management. Now, what is amblyopia? First of all, amblyopia is also called as lazy eye. Or lazy eye or amblyopia means loss of vision without any organic cause. So we know once amblyopia sets in completely, there is no treatment for it as such. That's why the word treatment is not used. It is used management. When we are talking about lazy eye, we are essentially talking about prevention. Now, when a patient with amblyopia, or let's say a child with amblyopia comes to you, the first thing you will think of is that there is a refractory error which the patient has not been using. So always the first step is to give the refractive error correction. Yes, if the vision is improving with refractive error correction, what more do you want, right? But once you have given the refractive error correction, you are giving the time for acceptance of the spectacles. Even after that, if the vision is not completely becoming normal, then you move on to step 2. And step 2 uses occlusion therapy. Obviously, along with glasses, guys. Occlusion therapy, what we call as patching. What are we trying to do in occlusion therapy or patching? We are trying to penalize, or we are trying to restrict the vision of the normal eye, and in effect trying to force the amblyopic eye to be able to see. The same thing can be done by penalization. In penalization, what do we use? We use 1% atropine eye ointment. Essentially, what are we trying to do? We are trying to make the child hypermetropic. Atropine will lead to loss of near reflex. Yes, it will lead to cycloplegia. Atropine, cycloplegia, ciliary muscle is not acting. The child cannot see at his toys, at his notebooks from the eye which has been penalized. So he will be forced to look from the other eye. So again, you are trying to penalize the normal eye in order to focus the amblyopic eye to work more. Yes. So these are essentially the same things, occlusion or patching or penalization. Now, step 3. The new strategy we have are video games. What are video games doing? How are they working? They are working by some softwares, obviously some games which are making you see a motion in a particular direction, in a particular speed, or they are giving both the eye different stimuli. Okay, so based on those strategies, a lot of video games are being developed software based, which are again essentially forcing the eye to see and thus helping you overcome amblyopia. So the basic technique that we use, or the phenomena that we use, is called as perceptual learning. In perceptual learning, we are asking a specific task to be performed. It can either be dioptic games, which are giving two different stimuli to both the eyes, or they can be motion tracking games. So various techniques are getting used. Even Tetris is a very good game to overcome amblyopia, right? So yes, in 2022, a meta-analysis was done, and it was proven that video games, they are proving helpful in the treatment of amblyopia. I know that is the last thing a parent would want to hear when the child cannot see, that ask them to play video games, but there are certain specific software-based video games. Now, what about strabismus surgery, sir? So I hope, coming back, A and C would have been easy. That this cannot be the answer. The confusion may have been between video games or strabismus surgery. Plus, please understand, strabismus surgery has nothing to do with amblyopia. It is only correcting strabismus. Strabismus surgery we ask to do after amblyopia prevention. Essentially, first we are saying let's prevent amblyopia and then do strabismus surgery. That is what has been taught to you. Yes. So please remember, strabismus surgery is used for correcting strabismus, all right, but it has no role in amblyopia management. Refractive error correction, because we know anisometropic amblyopia is a very common type, so the first step is that. Then anisometropic amblyopia or strabismic amblyopia, in both cases patching and penalization are helpful, and then video games can be helpful in all types of amblyopia, right? So that's just a simple laydown. Again, this was probably a tricky question, but you could have done it right, and as I have heard, maximum students have been able to do it right. Next question, everyone. This was probably one of the easy questions. Again, direct, simple question. No thinking, no confusion should have been there. Which investigation is done to visualize all individual layers of retina in vivo? Now, the only way you could have done it wrong was whether if you did not understand what is in vivo. In vivo means in a living body. Yes, a living plant, a living person, a living animal. So I will write person because we are mentioning retina here. Yes. So in vivo, we are not saying in vitro. We are not saying take out the part. It is a dead part. Then you are visualizing it. You are visualizing it into a living harmonic body. Yes. So now which investigations out of the following can see the layers? Very simple. Don't even know ophthalmology. That's also okay. You just need to know radiology. CT scan, ultrasound, angiography, or perimetry. Obviously, the answer is CT scan. CT scan or optical CT scan or OCT, as we say, gives us optical biopsies. That's how I have taught it. Yes, we are doing an optical biopsy. That means we are able to see all the layers. And this is the kind of image that we are able to see of a normal OCT. That's what we have seen, all the layers of the retina marked. We can see where is the problem. We have seen so many OCT images to differentiate between CME, CSR. We know what is the subretinal space. We know retinal detachment. We have seen the layers of the retina over and over again via an OCT. B scan, ultrasound. This just shows us, the spaces. It shows us the lens, then it shows us the retina and the vitreous cavity. Fluorescein angiography, it just shows us the blood vessels and the macula. So that's what we have discussed. It is vascular disorders plus macular disorders, and perimetry is just visual field examination. So I think it was based on the options given. They were so easy that you could have solved it. There was no way that you should have gotten it incorrect unless you were just sitting in the exam for fun, just to experience how is the environment. This was an easy question which all of us have got right. Moving on to the last question, the question number 8. Again, this just looked difficult. This was easy. The question was essentially on optic neuritis. In optic neuritis, which of the following statement is true? Now, some people said which of the following statement is true was asked. Some said which of the following statement is false was asked. Some said option D was only 4. Some said option was only 3. So I'm not going on the options or the question. I'm just trying to explain you all the 4 statements here. 70% patients of multiple sclerosis present with optic neuritis. This is a false statement. Why? Initial presentation is 15% to 20% patients. Once during MS, optic neuritis shall affect 50% patients. Whether they were trying to ask the initial presentation or the overall presentation in terms of prevalence, both the figures do not go up to 70%. So we are confident that this was a false statement. Now, option 2, this all of us knew. This though we knew is false. We did not have to think oral steroids are appropriate treatment. No, sir, no. We know we need to give IV methylprednisolone for 3 days, followed by oral methylprednisolone or prednisolone for 11 days. This though we know, this we have studied, we have even read that only oral steroids, if given, they increase the chances of recurrence. Yes, so we know this is false. Option 3, it can have normal fundus with no disc edema. We know that it is true beyond doubt, because we know that optic neuritis can present as either only papillitis, as retrobulbar neuritis, or as neuroretinitis. We know, we have read again and again, retrobulbar neuritis means that there is no swelling of the optic disc behind eyeball. We may have remembered, we read it like this: both the patient and doctor cannot see anything. Yes, both patient and doctor cannot see. Patient cannot see because there is the disease of the optic nerve, and the doctor cannot see because there is no problem inside the eye. So the doctor cannot see the problem, but the patient cannot see the doctor. Right? So that's how we describe it. So we know, yes, it is true that optic neuritis can have a normal fundus with no disc edema. Now, option 4. Color vision and contrast are proportionately affected to vision impairment. See, we know color vision is affected. We know contrast is affected. We say red, green color blindness. Yes. But whether they are affected proportionately to visual impairment, there is no record of such a state. Again and again, it is mentioned that color vision should be measured on the initial visit. That is part of the workup. Contrast is lost, contrast is poor, but there is no mention of the fact whether it is proportionate, whether it is sequential or not. So, in all entirety, this is also wrong. Okay. So, if the question was in optic neuritis, which of the following statements is true? Then the answer is only option number 3 is true. Or the answer could have been 1, 2, and 4 are false. Any of the two. Again, the options may have been jumbled. So even though the options given to me are 1, 4, 2, 4, 1, 3, 4, and only 4, the statements may not have been numbered as I have been told them. So see, in such questions, to arrive at the appropriate answer, what was asked in your question is very difficult, because there are, first of all, A, B, C, D options. You may be jumbling them up, and then you may be jumbling even the options, right? But what we know is what is true and what is false. The options we know. So only 3 is true, 1, 2, and 4 are false. Any of the two answers would do. Yes. So these are the 8 questions asked. As you would see, again, a very well balanced examination in between image based questions and theoretical questions. Though I must say this was probably an easier question than, or easier examination than have been asked previously. Uh, Only 1 or 2 questions were a little tricky. Rest all the questions were pretty simple. As you would see, we are going back. Yes, starting with the question on diabetes mellitus. And I think this is what we'll expect in the future also. Questions based more on concepts, based more on relevant topics rather than on irrelevant topics. NEET PG will again test you in ophthalmology. Supposedly, it should be a little easier than the INI-CET exam. That is what we think. But as I again say, difficulty is just relative. Difficulty is in your mind. The more you study, the less difficult you find the examination, and that is what we want to achieve. We want to keep excelling. We want to keep reading. We want to keep doing MCQs. We want to concentrate more on doing the multiple choice questions, because at last that is what is going to be asked in our examination. When we were children in school, we used to have theory examinations. We didn't practice MCQs. We practiced theory answers. We practiced writing answers. We practiced the steps of the answer. And that is what we want to do. We want to practice what is going to be asked in the examination. So please keep following such videos. Keep following me for more. If you want to follow me, you can uh, Instagram me. I think that's the best way to connect with me. And Instagram can be done on this ID. Please feel free to contact me and any of the other faculties whenever you are having any problem. Thank you, guys.